cases. قبل ما نعمل الهاندز اون I brought for you some cases to apply the knowledge in practice قبل ما نعمل الهاندز اون. أنا اسمي دكتور حاتم سليمان، أنا بشتغل في رويال برومبتون وهيرفيلد هوسبيتال إن لندن. عندنا طبعا very briefly في الأول historically لما نبص على الميديسن والفيموس تكست بوكس هاريسون، كان في مقولة للأسف يعني أو مش للأسف لحسن الحظ ثبت إنها خاطئة، لأنه هو دكتور هاريسون قال في التسعينات إن lungs are major hindrance for the use of ultrasound and they are not suitable for ultrasound. يعني مقولة قوية جدا، بس طبعا ده كان درس إن إحنا نبقى humble ومتواضعين مع العلم، لأن في نفس الوقت اللي كان دكتور هاريسون بيقول ده، دانيال ليكتنستين وهو فرنسي anesthetist anesthesiologist كان بيقوم بأول ريسيرش يanalyze the artifacts of the chest generated by using ultrasound on the chest wall. And it's ironically at the same time that Dr. Harrison said the lungs are not suitable for ultrasound. And Daniel told us, no, it is suitable, you can use it. And that's the beginning of the ultrasound revolution. So if you go and try on PubMed, and this is back to 2022, so even a year back, you will see that if you write lung ultrasound in search, you will see how the number of publications increased over the years. It's a proper revolution. A massive increase in the number of publications, which reflects the huge interest in lung ultrasound worldwide. One of the main things which exploded the use of lung ultrasound is the COVID-19 pandemic, because many clinicians realized that they can use lung ultrasound reliably as an alternative to chest X-ray. And that's what we will discuss again in this lecture. So what are the principles of ultrasound? The principles are mainly that it is not transmitted through air. That is correct. So Dr. Harrison was partially right in saying that the air does not allow ultrasound to be transmitted. But we have to be careful that the artifacts generated by the ultrasound can be analyzed. This is the trick for understanding lung ultrasound. The normal parenchyma of the lung, the normal parenchyma of the fully aerated lung is not visible. So if you put the ultrasound probe on the chest, you don't expect to see something like the liver, because the liver is a solid structure. The lung is not a solid structure. Normally the lung is full of air. And this air makes you unable to see the parenchyma. But if you see the lung becoming solid like the liver, that is abnormal. That indicates loss of air in the lung. Well, this is what we call consolidation. To do ultrasound in general, one of the principles that you need an interface. Interface which reflects the ultrasound beam. And in lung ultrasound, the interface is what is between the pleural layers. And this is what reflects the ultrasound beam. To do ultrasound, again, you need to have an acoustic window, which is the window for insonation, or the window for ultrasound beam to go into the body. And here the window is the intercostal space. This is the beginning, okay? So now we know the window to the chest, which is the intercostal space. We need to keep in mind while we started learning lung ultrasound that there are many advantages. Many advantages. It is immediately available at the bedside. It is easy to learn, much easier than echocardiography. So if you are performing echocardiography already, this is a very easy tool to learn. And if you are not doing any ultrasound at all, this is the easiest modality of ultrasound to learn. And the literature and the data proved that it has a steep learning curve. So in the UK, we have the accreditation for lung ultrasound, which only require 30 scans, which is a much smaller number to compare to the 150 needed for cardiac ultrasound. This is only to explain to you how much easy it is. The other principle is it is rapidly applied at the bedside. It's a point of care. It can potentially save lives because you can enhance your physical assessment by the information you get by ultrasound, and therefore you can reduce cost, because now there are many data which prove that lung ultrasound is much more specific and sensitive than chest X-ray. Much more sensitive and specific in various aspects. So you can reduce cost by reducing the number of X-rays. And finally, it is more safe because you reduce radiation exposure, and you also reduce exposure of healthcare professionals to certain infections. And that's what we witnessed in the pandemic. During the pandemic, we all had the COVID areas. We tried not to expose radiographers to COVID patients. So we, as intensivists, as cardiologists, did the assessment, keeping one machine in every unit, and that is safety. Moving forward, how do we do it? You need a probe, you need an ultrasound probe. And are you all already practicing cardiologists? All of you. So you know what is the ultrasound probe is. And actually today, we are going to use the cardiac probe, because to scan the parenchyma of the lung, because it's a deep structure, you need a low-frequency transducer. You all know what is low frequency is. You all know it. So low frequency, deep penetration, and that is the cardiac probe. But if you have the curvilinear probe, which is the abdominal probe, that is the universal probe that is more recommended for lung, because the lung is, the intercostal space is broad. So if you have the curvilinear, it is better. If you don't have it, it is not an excuse. You can easily use the cardiac probe, and especially if you are doing the lung ultrasound as part of your echocardiographic assessment. So I highly recommend that you do the cardiac assessment, and before leaving the probe and moving from the chest, just go on the lung. Okay? What about the pleura? Because the lung is not only the parenchyma, the lung is also the pleura, which is the most superficial part of the lung. The pleural assessment requires a high-frequency transducer, which is the vascular probe, the one we use for vascular access, for line insertion. So when you put this probe on the chest, as I will show you, you will see the pleura as in high definition. And then you will be able to identify any abnormality in the pleura, in the thickening of the pleura. So the pleura normally should be thin, as we will see, should not be very thickened, and normally the pleura should be showing what is called sliding. I will show you all of this. So these are the transducers. What is the position of the probe on the chest? There are many protocols, because as you can imagine, ultrasound is not like X-ray. X-ray is a universal scan. It gives you a global view of the chest. Although it has many limitations of poor sensitivity and poor specificity, but it remains a universal scan. Ultrasound with the very high sensitivity and specificity is a focal scan. So that requires a more protocolized assessment. So there are many validated protocols. This is the simplest protocol available. It's called the Blue protocol, and it is mainly validated in emergency situations, or if you don't have time, you can quickly put the probe on 3 points on each lung. You have 2 anterior zones and 1 lateral zone. So 1 upper, 1 lower, and 1 posterolateral zone. And that will tell you briefly an overview of the lung. If you have more time, as you are doing this in an echo lab, you have more time to spend to your patient, it is recommended to do more systematic approach or more detailed approach, where you do 6 zones on each lung. So 2 anterior, 2 lateral, and 2 posterior. So you have flexibility depending on how much time you have with your patient. In these 3 points, what do you think is the most important point? In someone who is supine and sleeping on his back, what do you think is the most important point? Posterior. Excellent. Why? Fluid, exactly, by gravity. So fluid and also consolidation. Once you learn ultrasound with me today, you will go back to the hospital, try to scan your patients in the hospital. I can assure you, you will see many of them having consolidation in the lung, undiagnosed. And many of them, because of being lying in bed, even if they are not in intensive care unit, especially elderly patients, they have this tendency to have collapse of the base of the lung. So this is the point about the posterior location. So now I know which probe to use. I know which position to put. Now, where to put the probe? Which direction of the orientation marker? You know, we have in every probe orientation marker, which directs me to know which is which on the screen, right? So there is an orientation marker. So if I am checking for pneumothorax, which is one of the things you can diagnose with ultrasound, you need to put the probe at the top of the chest, because air goes up and fluid goes down. So top of the chest An indicator of the probe will be towards the patient head. That's the starting point. Again, don't worry about this. We will do it together, and we will see the images. If I'm checking for effusion, where to put the probe? Pleural effusion? Yes, at the base, exactly, because fluid goes down by gravity. If I'm checking for consolidation, where do we put the probe? What do you think? Sorry? Yeah, different places, but where to start? Consolidation. Consolidation, same like effusion. It always starts at the base, unless you have trauma, local trauma. But usually atelectasis, effusion starts at the base. If I'm looking for congestion, I have to do all zones, of course. I mean, you will do all zones anyway. But with congestion, the signs of congestion, as we will see, again, are more obvious at the base in a supine position. All right? So next, let's go to the analysis of the artifacts. What do we see when we put the probe on the chest? This is the first normal artifact. When I put the probe on the chest, and I'm using now the phased array transducer, the cardiac transducer. I put the probe on the chest. The indicator is towards the patient head, okay? And then I am looking on the screen and trying to see what is this. The first thing I will see is two black or vertical shadows. These are the rib shadows. You know, bone does not allow ultrasound to be transmitted, so instead you will see a dropout. So that is a bone. That is the dropout. This is the rib. This is a dropout. This is the rib. This is dropout. The most bright, shimmering horizontal line is the pleura. So this horizontal line at the top is the pleura. And what happened now is you are seeing what is imagined by Daniel Lichtenstein, the inventor of lung ultrasound, that it is called the bat sign. You know the bat? So this is called bat sign or bat wing. The bat wing sign is confirming that you are located at the level of the pleura. Because if I don't start vertical, if I don't get the two rib shadows like this, I might think that the pleura can be any of these horizontal lines at the top. But this rib shadow is the landmark at which I am sure this is the pleura, because the pleura is connecting the two rib shadows. Did you get it? This is the starting point. It's called the bat sign. And the best way to get it actually is done by the phased array probe. You remember we said which probe to use for the pleura? You remember? Pleura. Vascular probe. The best probe is the vascular probe. Well, actually, in this image, this is vascular probe. That's why you see the rectangular appearance of the image. So moving forward, now this is a phased array probe. You see the difference is deep. So the image is deep, the sector is not squared. And now this is what... these are videos, actually. The videos, it has to work. Just 1 second. So this is a phased array transducer. We are back. You see, now you see an artifact. So can someone describe the artifact for me? How does it look like? What do you see? Horizontal reverberation. This is reverberation artifact. So what happens is, at the top of the screen here, you have the pleural line, the brightest horizontal white line at the top. And underneath, you have reverberation of that pleural line horizontally, and these are called A lines. A lines are the foundation of lung ultrasound, and A lines indicate air. So A means air, and air means no fluid. So if you see only A lines like this, that means your lungs are dry. And this is much, much, much more accurate than clinical assessment, much more accurate than X-ray, than symptoms and auscultation. But also you can see A lines in pneumothorax. But forget about pneumothorax now. I don't want to confuse you. I am focusing on congestion and heart failure. So these are the A lines. This is a different artifact, and that's called B line. So we started with A, horizontal, and then you have vertical artifact called B lines, and B lines indicate fluid. I'm not talking about fluid in the pleura. I'm talking about fluid inside the tissue of the lung. That is congestion. And that is what you exactly see in a congested patient. Again, at the top, you are seeing a pleura that is looking thin. The normal pleura looks like that, thin, not thickened, not irregular, because if the pleura is thickened and irregular, that is abnormal, and this is what we see in infection, in pneumonia. But this pleura is absolutely normal. This is how it looks like. And from this pleura, you have vertical lines. They call it laser-like beams. And these laser-like beams start from the pleural line and go all the way to the far field. And what is more useful and interesting, that the bigger the number of B lines, the worse the congestion. So there is a strong correlation between the number of B lines and the degree of congestion in heart failure. And there are many data now that explains and validates using lung ultrasound to diagnose heart failure, to prognosticate, to risk stratify, and to assess outcome, and to triage patients. So these are the B lines. The main thing about the B lines is that when they grow in number, they hide the A lines. Because remember, it started with A lines, right? And when you see initially 1 or 2 B lines, that is normal. So you can have up to 2 individual isolated B lines in one intercostal space. That is normal. So to identify them as abnormal, they have to be 3 or more. Of course, if I ask you how many of these, there's a lot of them. So that's abnormal, definitely. And the higher the amount of B lines, the worse the congestion. And now we have 2 different grades of congestion. The early congestion is called interstitial congestion, where the fluid is in the interstitium of the lung, not yet flooded in the alveoli. And those patients are not very hypoxic. This is the patient sitting on the ward on diuretics, but congested, but not breathless, not hypoxic. He's likely to have interstitial congestion. But if you do it in someone with frank pulmonary edema, very hypoxic, this is the patient who will have alveolar congestion. And you can assess both by lung ultrasound, because the one with interstitial congestion will have individual separated B lines. The one with alveolar congestion, like this, you will have what they call coalescent B lines. They make what is called a curtain. The screen becomes a bright, shiny white, because every line is white. Do you get what I want to tell you? So now we are reaching towards quantifying congestion. And here you on, this may not work, but I wanted to show you that B line has to go all the way to the far field. So if you have a B line that stops in the middle here, that is not a B line. The B line has to be clearly, well-defined, starting from the pleural space, going all the way to the far field. Otherwise, it's not a B line, and it's not pathological. I mean, few studies just to show you the latest data we have. Lung ultrasound now is clearly validated in assessing congestion in outpatients, and they assessed 100 patients in this study. They compared lung ultrasound to the previously validated clinical congestion scores, which was the E over E prime, the chest X-ray, the NT-proBNP, and the 6 minutes walk test. And they found very good correlation between the number of B-lines and established parameters of decompensation. In this study, they found that 15 B-lines was the cutoff, but I don't advise that you focus on counting the number of B-lines. I would recommend more seeing the pattern of B-lines. Are they getting worse? Are they getting better? And that will be your guide for optimizing your therapies. And that's another study which looked at prognostication of patients, again, ambulatory heart failure by lung ultrasound. And they actually studied about 200 patients, and they found that patients who had abnormally elevated number of B-lines, we said 3 or more is abnormal. So patients with abnormal number of B-lines had 4-fold higher risk of the primary outcome, which was mortality in this study, compared to patients with lower number of B-lines. So higher B-lines compared to outcome. It reflects worse mortality. And another study, I mean, there are many data. I showed you PubMed, and even now lung ultrasound is in the heart failure guidelines of the ASC. It's one of the essential tools beside echocardiography. And we recently published from the European Association of Cardiovascular Imaging the first clinical consensus guidelines on using lung ultrasound in heart failure. It is open access, so I highly recommend that you Google it and download it. It provides a complete guidance on how to use it in these settings. So let's move on and tell a bit more about B-lines. B-lines are not only useful in heart failure, because seeing congestion is not specific for heart failure, because you can find patients with pneumonia, with wet lungs. Remember, fluid in the lungs could be hydrostatic and could be inflammatory. So hydrostatic is heart failure or volume overload. Inflammatory is infection or ARDS. And that is what we saw in COVID-19. Patients with COVID-19 had in the CT what was described as ground glass opacification, right? This ground glass is B-lines, is water, is patchy areas of fluid in the lungs. So it is also useful to evaluate pneumonia. It is useful to evaluate patients with renal failure on dialysis, to evaluate the efficacy of fluid removal. And we started with A lines, we moved to B, which is B line, and then we will move to, what is the following letter? C, which is consolidation. So now we have A, B, and C. And that is the grades of aeration in the lung. So we're talking now about patients with B lines due to infection. If the lung is dry without infection, it will be A lines. If the lung becoming inflamed with fluid, that becomes B line. This inflammation at some point will become solid, and then you will see consolidation. And that is the different grades of aeration in the lung, starting with normal aeration, horizontal A lines, to relative loss of aeration, which is the B lines, fluid, and a complete loss of aeration. And that is the only point where you see the lung anatomically exposed as a structure, like the liver. They used to tell us in pathology that this is called hepatization. You remember? And that's why this is consolidation, because you see the lung as a liver, as a tissue. And if you keep in mind the ABC approach, as we will do together, you will immediately assess aeration in the lung, because you can do it ABC, worsening aeration, or CBA, improvement of aeration. If patient with consolidation improves, the consolidation will be normalized to B lines and then to A lines, etc. And COVID-19, again, the pandemic exploded our use of lung ultrasound. And in this study, we correlated the appearance of CT, the ground glass, with the patchy areas of B lines. You see here, B lines, right? But these B lines were different from heart failure B lines because they are patchy. The heart failure B lines are bilateral. They are symmetrical, because congestion in heart failure is likely to be bilateral, likely to be symmetrical. The B lines in pneumonia and ARDS are patchy, and most importantly, the pleura is abnormal. Because if you have infection or inflammation, the pleura must be abnormal. It will not be thin. It will be thick, irregular, and actually this is a pleura. Do you see this? This is a pleura seen by the linear probe, the vascular probe. How does it look like? Is it thin and normal and regular? It is irregular, and you see this is called subpleural consolidation. And this is a hallmark of pneumonia. If you see this subpleural consolidation, that is a hallmark of pneumonia, and it was seen very commonly in patients with COVID-19. COVID-19 did not cause the full-blown ARDS. You all managed patients with COVID-19, right? They were not the patients with full-blown ARDS. Like when you put the ultrasound probe on them, you did not see consolidation everywhere. No, you see B lines, patchy B lines. So it was that patchy areas of fluid in the lungs due to the inflammation. And that is what I was just saying, the differences between ARDS and cardiogenic pulmonary edema, and that's one of the useful features of lung ultrasound. Looking at the pleura, pleura is normally thin in heart failure, thick, irregular in pneumonia, ARDS. In heart failure, the B lines will be bilateral, will be symmetrical. In pneumonia, the B lines will be patchy, asymmetrical. And in between these patchy B lines, you will see areas of A lines. And that is called spared areas. And that is very important in pneumonia, seeing the spared areas of A lines in between patchy areas of B lines. I think this is the beginning, the first half. Again, many benefits during COVID-19. We used it for triaging patients, risk stratifying, prognostication, and the same applies for heart failure. Exactly the same applies for heart failure, and this is what the guidelines tell us. Use it to assess therapy and to optimize doses of heart failure medications, diuretics, according to the number and the appearance of B lines. I think I am done with the first half. Maybe before finishing, I'll just show you the first something. So B lines, at the beginning of the talk, I said it is more accurate than X-ray. And it's even more accurate than auscultation. It is more accurate than symptoms. And this is an example. This was a case in the United States, presented to the emergency department, was a young guy in his early 40s, no past medical history, presented to the emergency department only with mild shortness of breath. His ECG was normal, was unremarkable. And the clinician initially wanted to discharge him, but someone said, let's do lung ultrasound, because he was slightly breathless. And I can tell you, lung ultrasound saved his life. Why? Because once the emergency physician put the ultrasound, he saw B lines everywhere, heart failure B lines. And ECG was normal. So they looked into the heart. They found evidence of diastolic dysfunction. They took him to the cath lab because they suspected very high left ventricular end diastolic pressure because of that very big number of B lines. The guy had a critical left main disease, was 95% left main. So they did immediate revascularization. And when they measured the LV-EDP in cath lab, it was 39 or 40. So the B lines were picked up early by ultrasound in someone who only had mild shortness of breath. And the message here is B lines can be detected early before hypoxia. And now they use it as part of the dobutamine stress testing. So if you see stress B lines when you put your patient on the treadmill or you give them dobutamine, that is an early indicator of congestion, much earlier before you see congestion on X-ray, before you hear it on auscultation, or before you see the patient complaining of symptoms. And that is the final one, which if you do echocardiography, augment it with lung ultrasound. Lung ultrasound alone is not enough to assess heart disease, but it is definitely a useful add-on to echocardiography. So doing echo, and don't finish before looking at the lungs, because when you add lung ultrasound data to echocardiographic evaluation, you can evaluate different types of shock, for example. And these are 4 different cases of shock. The one at the top, patient with septic shock. The heart was hyperdynamic because of sepsis. Clearly, the patient had big consolidation in the lung, and the patient had preserved end diastolic volume of the left ventricle. B, the second one, patient was congested, was heart failure, severely impaired left ventricular systolic function. Patient had dilated IVC, non-collapsible, and you see the B lines. C was a patient with obstructive shock. You see the D-shaped ventricle with RV dilatation, pressure overload, A lines on the chest because in pulmonary embolism, lungs are dry. And patient had a clot in the common femoral vein, a DVT. And finally, patient with hypovolemic shock after trauma. You are seeing here a heart that is small, empty. It is hypercontractile with which lines? Excellent. You're masters now of lung ultrasound. A lines, and finally the IVC is collapsed and not dilated. And that is the integration of lung ultrasound with echocardiography. Before we finish this part, I would like to quickly tell you limitations. Nothing in the world of medicine is perfect. So knowing the limitations is important, so we practice that safely at the bedside. As we said at the beginning, this is a regional scan, so it's not a global scan. So the more zones you will assess, the more accurate data you will get. But this should not stop you from doing it. Even if you do 3 zones, better than nothing. I can assure you, you will get plenty of information by only putting the probe on 3 zones, 2 anterior and 1 lateral. That's number 1. Know the limitation. So it's a focal scan, have a protocol at the bedside. It needs training, and that's why we are doing this today. So training and starting practice at the bedside with echocardiography. If you have pathology very deep in the lung, you might miss it with lung ultrasound. So this is not a diagnostic ultrasound. This is an assessment ultrasound. So we are not aiming to write a report and say this is diagnosis. No, this is not a diagnosis. This is assessment at the point of care. And finally, use it within the clinical context. For those who just arrived, welcome to the workshop. We're about to start the second half of the lecture, in which we will briefly mention what we discussed at the beginning, okay? The second will be cases. So we'll have 5 cases. We will discuss them together before we go and do a hands-on. Before we go to the cases, is there any question? Please don't feel shy. Any question? Does it make sense so far? Does it seem too complicated? It is not complicated, I can tell you. I know. Of course. Yeah, actually it's a transition. So the normal aeration, horizontal A lines, and then when the B lines start to appear initially, you will still see A lines underneath. Until one point when you have many, many B lines, the A lines will disappear. So it's a transition. You can definitely see B lines with A lines in the background, as we will see together in the cases. And in the cases, we will show you examples of consolidation as well. We have not seen full-blown consolidation yet. Okay? Can we get the second lecture, please? المحاضرة الثانية بعد إذنك. كيف الحال؟ تمام. المحاضرة الثانية سوري. So for those who just arrived, I will mention one thing. We discussed how to do lung ultrasound, but what I want you to know before we start, and whatever you missed we will mention in the hands-on, that assessing lung ultrasound is assessment of artifacts. You have 3 types of findings, A, B, C. I think that's the summary, right? A is called A lines. You will see horizontal lines, which are the reverberation artifact of the pleura, and that means normal aeration. B is B lines becoming vertical, laser-like beams, which indicates congestion when the normal air in the lung is replaced by fluid. And finally, C, which is consolidation. We all know consolidation. Consolidation is the lung becoming solid, called hepatization. And that is the only time you see the lung as an anatomical structure, because A and B are not anatomical structures, they are artifacts. Okay? So this A, B, C is the summary of using lung ultrasound at the bedside. Of course, C is not a heart failure problem, it's an infection or atelectasis problem, but it's commonly seen in hospitalized patients. So keep it in mind. Okay, are you ready for the cases? Okay, so starting with this case, again, yeah, I think in this lecture I put briefly what A lines are. It's your luck, the ones who just arrived. So A lines, horizontal lines. As you can see here, the pleural line is the most bright line at the top. The brightest white line at the top. This is the pleural line, and you see horizontal lines, which are mirror-shaped or reverberation artifact of the pleural line. These are not anatomical structures, but these artifacts are very important because they confirm dry lungs. They rule out congestion with much high accuracy than X-ray or symptoms or hypoxia. And then you see the vertical lines, the B. So when you see this, you think of congestion. And they are different because they are vertical. Your question was, do you see A lines underneath? You see some A lines. Because the B lines are not big, they are numerous, but they are not numerous enough to hide all the A lines. So that's the quantitative assessment of the B lines. Again, pleural at the top and the B lines. B lines have to be laser-like, well-defined. They have to start from the pleural line, and they have to go all the way to the far field. And they have to move with the pleural sliding. Do you see the pleural at the top? Is it moving with breathing? That movement of the pleura is very important because that is described as pleural sliding. And pleural sliding rules out pneumothorax. So if you have pneumothorax, you will not see pleural sliding. It will be lost because there will be air between the two layers of the pleura. And that will make the ultrasound unable to reach the inner layer of the pleura. So you will not see sliding. Okay? So these are the B lines. And this is something important. I didn't mention it earlier. We mentioned about the B lines, they have to be going all the way to the far field, right? And well defined. Do you see anything vertical coming occasionally here that is only reaching the half of the image? So that is not B line. So don't fall in this mistake. These are called Z lines, and they are absolutely normal. And you can see it in healthy people, in everyone, in people here in the room. That is not B line. Always remember that the B lines look like this. They have to be very well defined and clearly reaching the end of the screen. And these are Z lines. Non-pathological, absolutely normal. And that is the quantification of congestion, the assessment of the degree of congestion. Before looking at the vertical lines, you see that the higher the congestion, the whiter the screen. So at the top left, this is a patient who has minimal congestion. You see the B lines only coming in one area, focal area, and the rest is A lines or dry. But with rising congestion, you see more number of B lines and brighter screen, because a single B line is laser-like bright, like the sun ray. So the bigger the number of B lines, the brighter the screen becomes. You see the two images at the bottom? Brighter. Brighter because of these vertical lines. Of course, at the top, this is early congestion, and this is late severe congestion. And as I mentioned earlier, you have two different grades of congestion physiologically. The early congestion is interstitial congestion, where the fluid is in the interstitium of the lung, but not yet flooded in the alveoli. And this is the patient you see in the ambulatory heart failure clinic on the ward, not breathless, but has some B lines and will need some optimization by diuretics, and not hypoxic. But this patient will be different. He will not lie flat in bed. This is the patient who will be very hypoxic, breathless, because that is alveolar edema, where the fluid are flooded inside the alveoli. This is the one coming with frank pulmonary edema. Do you see the two different grades? Okay. Please stop me anytime if anything that you feel doesn't make sense. We already mentioned about this, the A, B, C, the grades of aeration. At the top, you have the A lines, normal aeration. In the middle, you have B lines. You have two grades of B lines. Interstitial B lines, alveolar B lines. Early congestion, late congestion. Mild, severe. And finally, again, this is not congestion, this is consolidation, but it's only to tell you what happens if the fluid in the lung is replaced by tissue. You will see that. So now the position of the probe is in the mid-axillary line. And this is one of the most important points in the 3 points that I mentioned earlier. Mid-axillary line, indicator towards my head, patient's head. And with this, you are seeing the liver, if I'm on the right side. Do you see the liver? You see the diaphragm? Do you all see the diaphragm? And then above the diaphragm, you should see A lines, normally. But do you see A lines? What do you see? Another liver. So that's what? That's the consolidation, absolutely. And that is the hepatization, which means total loss of aeration of the lung. And I mentioned, sorry? That's infection. I mean, infection, if clinically there is infection, but that is called consolidation. Consolidation is not a clinical term, it's a pathological term. Clinically, it can be atelectasis. If the patient has collapse of the lung without infection, it can be pneumonia, it can be tumor. So, but it is consolidation if we talk pathologically. Ultrasound data should always be interpreted within the clinical context. But if I see this in someone who has fever and rising CRP, this is definitely infection. And I always start antibiotics based on that. I work in cardiac intensive care. So many of my patients come after cardiac surgery with early sepsis, and we can detect early sepsis by this. And you can miss it if you don't see it. All right, let's start with the cases. First case. This is a 75-year-old lady with history of hypertension, and she came developing worsening shortness of breath, hypoxia, day 1 after surgery. She had elective right total knee replacement. It's a common scenario in the elderly, right? Unfortunately. So she was on the ward. She started to become febrile. She started to have hypotension. She started to have hypoxia. So we started giving her oxygen and always thinking, why? If you have dyspnea or hypotension, always think of ultrasound. So why is she dyspneic? Is it congestion? Is it infection? Is it atelectasis? After surgery, anything can happen. She might have been given lots of fluid, became congested. She might have had infection. So we started with cardiac ultrasound, usual, focused echo, and IVC small collapsed, and apical 4-chamber view. What do you think? Seems okay. So biventricular function looks all right. So it's a bit unlikely that she's congested, because although it might be diastolic dysfunction, but anyway, before doing tissue Doppler and evaluating filling pressures, we quickly looked at the lungs, because it might give us an easier answer. And that was the answer. Can someone tell me what is there? So do you see we are doing the 3 points on each side. But again, this is one shot from each of the points. So at the top right, what is this? Does that mean she's congested? Well done. And on the left, which probe is that?
Linear.
The linear, vascular, well done. Why we are using the linear? Because I'm looking at the pleural. And how does the pleural look like? Is it thin, regular? No. It's irregular. And you see this subpleural consolidation. And I mentioned earlier, this subpleural hypodensity is specific for pneumonia. You see it frequently in pneumonia, and we saw it in most patients with COVID-19. Remember, COVID is a peripheral disease. So patients got plenty of this. But I'm not talking about COVID here, okay? What about the base. I mentioned the base is the most important aspect of the assessment. What do you see here? First, this is the liver. If I'm on the right, it will be the spleen. If I'm on the left, and that's the diaphragm, and that is the consolidation. Sorry? Yeah, I think the clip is itself is a short clip. I agree with you. Normally it moves, but her diaphragm was okay. But do we have an idea now why she's breathless and hypoxic? Yeah. Do I need to give her diuretics? There you go. In our old practice, you could easily give diuretics in any elderly hypoxic patient. This poor lady had a small IVC, hypercontractile heart. She might be dry. And you might give her diuretics, she becomes more dry and get renal failure. But now you know the answer. So you start antibiotics. And again, while we are preparing and asking the nurse to prescribe, to get the antibiotic, we got the blood results. She had leukocytosis, CRP was high, procalcitonin was high, but unfortunately she was elderly, poor cardiovascular and respiratory reserve. This is the X-ray. Again, what will the X-ray tell us? Yeah, it looks like infiltration. You call it infiltration. But do you specifically know what type of infiltration? Can you tell whether it's... Huh? Yeah, the problem in X-ray that it doesn't tell me what is there. It can tell me the global picture of whether they are infiltrated or not. But it doesn't tell me if there is infusion, if there is conservation or congestion. Anyway, she became more hypoxic, unfortunately. She deteriorated and she required intubation. And we groaned her, flipped her, so we can try to improve the oxygenation. And we repeated the lung ultrasound. We were doing lung ultrasound twice a day for this lady. Once in the morning and once in the evening. Can someone tell me what is there on your left-hand side at the top? B lines. She had A lines before, remember? Yes. Now she has B lines. What is there on the other side? B lines. What's there at the bottom? Consolidation. So it's an ARDS picture really, right? Yes. And a bit of, because she has bilateral B lines, she might have developed congestion as well. Remember that both can happen. You can see patients with pneumonia, ARDS, and also congested. The clue here will be the pleura. If the pleura is irregular, thickened, that is ARDS. And the B lines will be patchy. Another thing about consolidation, there is something in this consolidation. Does it look exactly like liver or different? Why different? What is different in the picture? Liver is homogeneous, all gray. But here you have area that is very bright, very white, an area that is very black. This is called air bronchogram. Air bronchogram. And what happens is, the white is air inside the bronchi. The black is fluid. And that appearance of the air bronchogram is what defines consolidation. So you have two types of bronchogram. I don't want to complicate it for you, but this is important. Two types of bronchograms on lung ultrasound. Static air bronchogram, not moving. Dynamic air bronchogram. Can you see that? You see that air bronchogram moving in and out, breathing? The static air bronchogram is likely athletics, collapse. Dynamic air bronchogram is 90% pneumonia. And that's the message. So if you see dynamic air bronchogram, it happens in pneumonia, not athletics. But this is most likely athletics. So how many information you can get by just putting the probe on the chest? Okay, so the lady has ARDS, and anyway, I want to tell you that she recovered. She was put on ECMO, and she had multiple bronchoscopies, and she responded to antibiotics, and thank God, she recovered. The second case. Any question before we move on to the second case? Any question? For the newcomers, any question? I hope you were able to catch up. Are the newcomers all cardiologists as well? Imagers, all echo? Good. So second case, ready? So second case is different. 76-year-old lady had recently a metallic mitral valve replacement a few days ago. And again, shortness of breath. So shortness of breath, again, increasing oxygen requirement, the same question. Why is she hypoxic? Why is she dyspneic? Is it congestion? Is it consolidation? We don't know. We did the X-ray. We did an echo, bedside echo. Echo was fine. Preserved by ventricular function. And what is there in the X-ray? Did the X-ray tell me something specific? Maybe there's some opacity at the base, especially the right base. Someone might tell me it's consolidation. Other might tell me it's effusion. Other might tell me both. I cannot tell precisely based on X-ray. So that's why my team did ultrasound. And look at the clarity of the image. At the top, what do you see there? Any congestion there? No congestion. I like it. No congestion. Excellent. The A-lines. And at the bottom, what do you see? Pleural effusion. And you see ellipsis. You see that? Is it the same as the air bronchogram that we saw? So if you don't see that air bronchogram, it means ellipsis. Collapse. Especially if you see a lot of fluid around it. Because that becomes compressive atelectasis by the pleural effusion. And actually, she has it bilaterally. So even that on the right side, she has bilateral pleural effusion and bilateral atelectasis. We can give her diuretics for the effusion, because that might be an indicator for heart failure, even if she's not congested in the lungs. And of course, telling her physiotherapy to mobilize her, to breathing exercises. But I think we understand why she's hypoxic now. Next case, 68-year-old gentleman, history of hypertension, diabetes, coronary artery disease, had recent aortic endovascular surgery. He had a big amount of blood loss intraoperatively, 1.5 liters of blood loss, required transfusion. And while the anesthetist in theater, he tried to help the patient by giving her more PEEP and giving more fluids and vasopressors, because the patient became hypoxic and shocked. And it was surprising because the more PEEP the doctor was applying, the patient was having worsening shock. What's going on? Initially ECG. There is some ischemic changes. Inferior ischemia, ST segment elevation. You agree? Some reciprocal depression in the anterior leads. And AF. So it could be cardiac. The ECG triggered the anesthetist to think of a cardiac cause. So it might be cardiogenic shock. So he kept giving more inotropes. But then someone said, let's do lung ultrasound. And that's what they saw. Let's look at the left, at your right-hand side first. This is which probe? The vascular. You see the image on the screen. That's the vascular probe. And it's a rectangle. So the pleura is moving. That is the pleural sliding that we mentioned is normally seen. If you see pleural sliding, you rule out pneumothorax by 100% sensitivity. So here, there is pleural sliding, you see it? And here, there is pleural sliding. Right? You all agree? Yes. What about here? Do you see pleural sliding all over the pleura? Do you see absence of sliding or part sliding and part not sliding? Excellent. This is called lung point. If you see lung point, which is area sliding and area not sliding, that is the most specific sign for pneumothorax. And here, no sliding at all. So that gentleman had tension pneumothorax. And that's why the doctor was increasing the peak on the ventilator. The patient was getting worse. And confirmed by M mode. That was confirmed by M mode because when you see the sliding and apply M mode, the pattern described is called seashore sign. Seashore. Because the chest wall will appear as waves. The pleura will be the very bright line, which will be the breaker of the beach or the seashore. And finally, the sand, which will be the lung parenchyma here on your right-hand side. You see the sand? The heterogeneous pattern. This is called seashore sign. If you have loss of sliding, the pattern will be different. You will see barcode or stratosphere sign, which is only repetition of the chest wall. If you have air between the visceral and parietal pleura, you will not be able to see the sand. So you will see repetition of the chest wall lines. And that's what is the barcode, and that is confirmation of loss of sliding. And this is not very relevant now, because in the latest guidelines, this will be removed. So it's mainly the 2D assessment of the lung point as a specific sign for pneumothorax. And that's why the patient got pneumothorax, because the anesthetist put a subclavian line without ultrasound. So back to the use of ultrasound. And finally, I think maybe the last case. Before moving to this case, any question? Cardiac. For pleura? It will be less clear because the cardiac probe is a low frequency probe. If I don't have linear, I can use it and make it very shallow. So I reduce the depth to focus on the pleura, but it will not give the same image, because the frequency is low. So pleural assessment, especially if you look for pneumothorax, ideally you should use the linear probe. But for heart failure, congestion, of course, cardiac probe or curvilinear probe. Okay, next case, 56 years old, gentleman, ischemic cardiomyopathy, so known to have poor ejection fraction, and he presented with cardiogenic shock. So we already know that he has poor cardiac function. He came with cardiogenic shock with worsening renal and liver functions. Admitted to ICU. Before I move on, that's the X-ray. Again, what do you see in the X-ray? Anything definitive in the X-ray? Nothing definitive. So maybe some opacity at the lower base, maybe the left base is not open enough, right? But is it effusion? Is it consolidation? Do we know? I don't know. I cannot tell without putting ultrasound. But we started with cardiac ultrasound in this patient because he's cardiac. We wanted to assess filling pressures and assess cardiac output. So we did LVOT VTI at the top. It was low. So patient has low cardiac output. And when we evaluated the filling pressures, it's clearly high. And patient has severe diastolic dysfunction. So we expect to see what on the chest? Ah, amazing. Well done. We expect to see B lines, and it didn't disappoint us. It is there. So we saw B lines, bilateral, symmetrical B lines on the chest, but it was not only B lines. You see effusion and you see consolidation. Remember, consolidation is the term, pathological term. It can be clinically described as infection, which is pneumonia. It can be atelectasis, collapse. It can be pulmonary infarction, if you have pulmonary embolism. It can be tumor. They are all consolidations. Okay? And that is the pattern of the patient after starting diuretics. What do you see? You still see B lines, right? But are they the same number or less? Much less, exactly. And you start to see A lines because that means there is more air than fluid. So less B lines and more appearance of the A lines. So that's response. And finally, patient at one point required kidney hemofiltration for the kidney. And look at the pattern now. Dry. So now you are sure that patient is dry. And that could be your guide for stopping hemofiltration or reducing the fluid removal. And I think the final case is a COVID case. Are you interested in seeing a COVID case? Yeah, just hopefully it will not come back, but just out of curiosity. So 55 years old, patient, non-diabetic, hypertensive, risk factors for COVID, came to us admitted, intubated, ventilated for COVID-19. That is the CT. We all know the CT, COVID, patchy ground glass opacification. Very typical. You don't see the full-blown consolidation in COVID. You see patchy ground glass. And ground glass is correlated with B lines, correlated with patchy number of B lines. And that is exactly, look at the striking picture in COVID-19. It's striking. And that is what we saw in the majority of patients with COVID-19. Impressive amount of patchy B-lines. And you know what? Why I mean patchy? Because you see spared areas in between. Do you see here? You see this area? Spared. And this area? Spared. And this is black. This is patchy B-line. So patchy areas of alveolar edema. How is the pleura? Is it thin, healthy, or thick, irregular, unhealthy? Absolutely, and that's one of the features of COVID-19, abnormal pleura. Pleura was abnormal, and of course there were some consolidations at the bases. And using linear probe in these patients also showed striking features. Look at the pleura, linear probe. What do you see? Is it small or big? It's big, and I tell you something interesting. Some described these big wedge-shaped consolidations as pulmonary infarction. We know that patients with COVID had thrombophilia, and many of them had PEs. And some argue that this could be the pulmonary wedge-shaped infarction in patients with COVID-19. You see how big it is? It is massive. It is massive. And that's one of the features of ARDS in general, but we saw it very frequently. You want to take a picture, sorry. We saw it very frequently in COVID-19. This is the one. Okay, patient was put on ECMO for 2 weeks, started improving, and there you go. 2 weeks time, lung ultrasound every day. During ward round, we do lung ultrasound during the ward round. And as soon as the patient starts to clinically improve, you will see improvement with the trend of ultrasound information. What do you see at the top? What do you see at the top? A lines, excellent. Normal aeration, totally different from the patchy B lines that we saw initially. And what do you see at the bases? On the right base? A lines, which is normal, normally seen A lines. What do you see at the left base? I will tell you something else, a little bit extra. So this consolidation, does it all look the same or different in part and different in other parts? Well done. So how different? There is part homogeneous and part heterogeneous. The part homogeneous is athlexis. The part heterogeneous is pneumonia. And that's the power of ultrasound in telling you the specifics of even inside the consolidation. Pneumonia is likely to be heterogeneous with, what did we describe this earlier? Air bronchogram, excellent. And this athlexis is definitely athlexis because it is homogeneous. And that's it.